Good morning, everyone. I'm Dr. Anwar Murad, and this is Dr. Salah Taqi. We will be the moderators for this particular track on GI in the critical care setting. So we're going to have the speakers give their talks, and then at the end of each talk, they're more than welcome to come and join us here in the chairs. And then at the end of all the talks, we'll have our Q&A session.
We have very exciting speakers. I'm sure it's a very special. It's going to be a very special session. So tune in, inshallah. We'll try to learn the most from these renowned landmark speakers. At the end, we'll have questions and answers, and save the heated questions till the end.
So I have the pleasure of giving the introduction for the first speaker, Associate Professor Emma Ridley, who is a Senior Research Fellow and NHMRC Emerging Leadership Fellow from 2020 to 2025 at Monash University, Melbourne. She's responsible for strategic development and leadership of the Critical Care Nutrition Program at the Australian and New Zealand Intensive Care Research Centre. She's a global figure in nutrition and critical care with several invited speakerships and conferences and more than 95 publications, including the New England Journal of Medicine and invited commentaries in The Lancet. And she'll be giving us a talk on assessing nutritional requirements in critical care in the year 2025. Thank you.
Louise, so I'll just wait for the microphone. Yeah. Very nice to be here. Thank you so much for the invitation. My first time in Kuwait, so I'm really looking forward to enjoying all the food and the hospitality, and it's just wonderful to be here, so thank you so much. And I'm just thrilled actually to have nutrition on the program and to be a non-medical speaker that's invited to come. I think it's excellent, so thank you so much. I'm really happy to have this topic. It's pretty controversial, so it's a good one. So let's talk through and see how we go, and very happy to have some questions or controversies at the end. Just a few disclosures. I've had some unrestricted grant funding from various industries and some associated speaking fees, but I don't believe it bears any influence today. A further disclosure is the more that I learn, the less I realise I know. I too feel more confused sometimes based on the evidence about what we should do with nutrition. And so I think if that's how you feel in your practice, hopefully we'll clear that up for you today, and you can also start to have more confidence around some aspects. And just as other aspects of critical care have evolved, so is nutrition. And this is very exciting. And early in my career, I felt this is how the road might go. But it actually is like this, and we are about halfway through this journey, I think, on this very windy road. To understand where we're going first, we must look back and see where we've come from. And so I'm not going to bore you too much with history, but I think it is important that we understand where we've come from in nutrition, set the scene, and then that helps us understand where we are today. A really quick reminder of the components of total energy expenditure as we go through, and this will be really the only, I guess, scientific aspect in terms of physiology and metabolism. But basal metabolic rate is a basal energy expenditure at rest, and we add on top of that diet-induced thermogenesis, which is the thermic effect of food. And then if you're moving around, you also have a physical activity effect. In critical illness, we remove that activity often because patients are sedated and ventilated. And so really what you have is basal metabolic rate, the stress response, and the diet thermal effect of food. It really all started back in the late 1800s with James Arthur Harris and Francis Benedict, and they did this seminal piece which was a biometric study of basal metabolism. And if you're a metabolic nerd like me, I would encourage you to go back and have a look at some of this work. It's very interesting to really understand and set the scene. But as I said, it's from a very long time ago. The sample size is relatively small, so more than 100 years old. And up until relatively recently, like 20 years ago, people were still using this equation. So I probably don't need to explain to you how much our population has changed over time and why that might be inappropriate. The equation was updated in 1984 to a total of 334 subjects, but that's not many. And it added an additional 74 people. In 1942, David Cuthbertson wrote this seminal piece from The Lancet on post-shock metabolism. And he really started to talk about these phases of illness, which we still talk about today. And so in the early phase, we call that the ebb, and it's decreased metabolism. And in that period, they were saying requirements were around 20 kcals per kilo. I want to be clear, that's not what we say today. This is what was put forward in that previous piece. The flow phase is increased metabolism, so that's really when that patient comes out of that acute period, and they were also thought to have higher requirements in that period. More recently, we've been talking about this anabolic recovery phase, which is also subject to increased metabolism. There's lots to learn in this period, and perhaps this is when nutrition may be most important for our patients. Further to that, in 1979, Long developed injury factors. So this gets to the point of how much do patients' metabolism increase when they're critically unwell. And so they did a series of studies and came up with a figure like this to show how much percentage above basal metabolism. Major burn, as you would anticipate, is still to this day has one of the highest increases in metabolism. But also how much has medical management changed since 1979, and surgical management, and obviously the response to the metabolic response to illness is going to change with those changes, probably be less, I would say, in many cases. This has again been updated, but still, it's still 30 years old at this point. And then Graham Hill, who was a surgeon from New Zealand, had a very keen interest in nutrition and has done a lot of really nice metabolic studies looking at the metabolic effect of illness over time. And this study goes out to about 25 days. And you can clearly see, I like this graph because you can clearly see that ebb and flow phase starting off lower with the black dots there, and then a peak, and then gradually trending down. So it really does show that these patients go through this metabolic process. Doesn't mean that that's what we should actually follow, and that I will get to that soon, but this metabolic process does happen. The anabolic phase, or this later phase, is often longer than the first two phases, but it's the phase where we know there's many problems with nutrition and we actually don't do very well. Around the 1970s, the parenteral nutrition was developed, and this really started this concept of hyperalimentation. And so what the belief was is if the patients have this metabolic response, we should chase that, we should provide the energy and protein that these patients are predicted to need. And so that's where that concept of matching energy expenditure or protein need comes from. In this period, we saw a huge increase in hypoglycemia, infections, deranged LFTs, complications associated with overfeeding, because that's exactly what was happening. And that's where that premise of overfeeding and the concern around overfeeding comes from. So what does the evidence tell us now? And so just a crash course on evidence. So the highest quality evidence sits in the top section here, which is systematic reviews of well-conducted RCTs or prospective RCTs. Following that is the lower quality evidence, and whilst there are now many high quality studies in nutrition, the large body of evidence still sits in the lower quality studies, and so we have to be aware of that. What's the problem with that? Well, it's mostly observational data, and 15 years ago that was really all we had, apart from a couple of studies. And what is the problem? And this is not a criticism of this work or this group, because they have done a lot to advance our knowledge, but just to show you that this observational data should only be hypothesis generating. And so this study found that an increase in 1,000 calories per day was associated with a reduced mortality, and that this occurred at the extreme ends of BMI, so low BMI, high BMI. This led to an assumption that perhaps then nutrition would save lives, and this is what we should be doing. We should be enhancing nutrition delivery. This has not been shown in any definitive clinical trial to stand up. It should only be hypothesis generating, but the risk is when you're dealing with low quality evidence and that's all you have and it's expert consensus, that it gets adopted into clinical practice early, it's what we do, and actually it's not the right thing for our patients. And as I've mentioned, multiple large RCTs now show no indication for benefit with aggressive feeding strategies and a potential for harm early in critical illness. So then the question becomes, does this mean that nutrition is not important? Because that's something that's been said to me before, well, nutrition doesn't matter. I put it to you that's not the case, and hopefully I'll convince you of that by the end of the talk. But that's the thinking that people now have, well, we don't need to worry about this. So why have we had no indication of benefit and perhaps an indication for harm? It may come back to this phase concept, which was introduced very early on in the 1920s, as I showed you. And really the importance of nutrition is now thought to vary according to phase. So in this acute early phase, and when I'm talking about days, but it's important to say there are no markers for these phases. We talk about days, but it's just conceptual, and ideally we would have a marker that we could measure, but I am talking in days, but that's not always the case. So in this period, we think hypocaloric energy and protein nutrition is what is required, is best. The acute late phase, perhaps we should, and the late rehabilitation phase, perhaps we should be aiming a little bit higher. This is based on the ESPEN guidelines, which have not been updated since these more recent trials have come out, and I'll be interested to see whether they pull their recommendations back further when they update their guideline. It's thought that this late rehabilitation phase may be the key period for nutrition rehabilitation. No trials, all trials are focused on this early period and this late period, so up to about 7 days of intervention. Some are getting out to about 12 to 14 days, but predominantly days 5 to 7 is all we've really studied, with no trials intentionally focusing on this late period. So it's very important to understand where the evidence sits. So we have evidence in that first sort of 7 days of ICU, but later, after, we really have a significant evidence gap still, and so that doesn't mean that the concept of hypocaloric feeding should continue on forever, because we really have no evidence around that. Just to note on the role of indirect calorimetry, and this is me and my colleague Kate during COVID when we were doing measurements on our patients. So just to update you on the principles of indirect calorimetry, it is able to directly measure energy expenditure by determining oxygen utilization and carbon dioxide production. Using the modified Weir equation, it can then predict energy expenditure. And mostly in ICU, it's done using a ventilated mode, but you can use a canopy or a mask setup as well. Now, slightly controversial, many people talk about indirect calorimetry being the answer, it's what we should be doing. I have a slightly different view, and this was written by some of my colleagues, where really if you look at the trials, there's no definitive trials looking at indirect calorimetry that show that it's of benefit. That doesn't mean it's not a very useful clinical tool, but at the moment we don't have that literature. And that was their conclusion, that there's insufficient evidence from a mortality benefit, certainly. We showed something slightly different as well in terms of indirect calorimetry when we looked and did a systematic review and a meta-analysis of available trials. We certainly showed that if you use indirect calorimetry, you can increase your energy targets, so you can deliver more nutrition. That's probably one of the purposes. But we also showed that indirect calorimetry guided energy delivery was associated with increased duration of mechanical ventilation. Now, this review often gets ignored when data is presented about IC because I don't think it sells the story that people want to know. We didn't show any difference in other clinical outcomes, but we hypothesised that this is actually because when you increase energy delivery, which we showed you can do, this is in the early period of illness, this is actually due to overfeeding. And so that doesn't mean that IC is not a valuable tool. It means it's further evidence to show that perhaps in that early period this is not what we should be doing. So therefore, what is the role of IC? Well, I think it's to potentially protect against overfeeding in the early phase of illness, and that could be very useful from a clinical point of view. And I think later on it's to guide and personalise nutrition in the recovery phase, and I think that will be a key role for it later on. Now, who knew that Taylor Swift was going to join a critical care conference, but she infiltrates everything. We've moved to a different era, so we're now in the less is more era. Previously, we were in the more is more era. And Professor Arabi, who's here, has been writing about this sort of thing for some time, and Professor Todd Rice also wrote a nice editorial after the publication of the EPINIC trial. We've recently written a commentary, and there's been a really nice review also with Professor Arabi and many other experts just published in the BMJ. So I would really encourage you to access that state-of-the-art review. It's wonderful. And really what they're talking about is this change in the way that we provide nutrition. And also in other areas, we're seeing less is more. So this is the team trial. My colleague Carol Hodgson actually published this trial. And she showed that with early mobilisation, so with a high level of usual care mobilisation, but enhancing that mobilisation, they showed an increased risk of complications with the mobilisation. But it's important that it's not nothing. So we're not saying do nothing, we're saying do less than perhaps what we were doing before. But we're not starving patients, and with mobilisation, we're not just leaving them in the bed, we're just doing a little bit less than we were before. So what should you do in practice? So in terms of estimating nutrition requirements, my professional opinion is that it's not a basic skill. And often it's put that, it's simple, just guess a calorie, and it is a guess a calorie amount and a protein amount, and off you go. It's not. It's actually quite a technical skill, and it involves understanding metabolism, the impact of metabolism, and physiology around metabolism and critical illness. What you need to do is pay attention to phase, so certainly start low and slow, and remember that patients may bounce between phases, and this is why I'm saying don't just guess a number and walk off. So really pay attention to the phase, come back and look at how that patient's going, and maybe you've had a patient in for 10 days but they suddenly become very unwell, they go back to the start, they're now in an acute phase again, and we need to pull back potentially on the nutrition. And don't set and forget, which is where you would set a requirement and come back 2 weeks later. That's completely inappropriate. And what will happen is you'll have significant periods of overfeeding and significant periods of underfeeding, both of which may be particularly bad for the patient. What influences metabolism? So this is also important to have in the back of your mind. There's factors that we can't modify, like age, sex. There's anthropometric things like body weight or muscle mass. Muscle is the greatest driver of metabolic rate, so patients with a high muscle mass will always have a higher metabolic rate. And don't be fooled, patients with obesity can often have a very high metabolic rate because they often carry a higher percentage of muscle compared to other people because they're carrying a larger body weight around. Then there's things like the disease effects, so what sort of illness do they have, how hypermetabolic does that illness make them, activity status and things like that. So it's important to always think about these things in the back of your mind. Our guidelines have changed as well. So this is the most up-to-date guideline of the major societies. It's an interesting guideline. There's, sometimes it's not that helpful, I find, but at least it's up to date. And what's been said is really that between 12 to 25 kcals is acceptable in this first 7 to 10 days, just indicating that there's a large spread of evidence and we're really not often certain where we should be aiming. But I think certainly in that first 7 days, it's acceptable to pull right back. Long-term interventions are the gap, which I did highlight before, and I think it's very important to know we're not advocating to continue low and slow nutrition for a long-stay patient. That's obviously not probably going to end well. So just to talk through a little bit more, I was invited to author this publication with Professor Christian Stopp and Dr. Zhengli Li, and it I guess summarises our thinking at the moment. It provides a little bit of guidance. It's important to say this is an opinion piece. This is not a guideline per se, but it's an opinion piece that could provide some advice as to how we might feed the patients. So essentially, if the patient on this side is very unwell, we're going very low and very slow, and then as they progress, we can slowly titrate the nutrition. And the important thing is that if the patient is deteriorating, you go back to this side here. And so that shows that significant loop of where you are assessing how the patient is going. And if you don't believe me, well, Professor Arabi is here, and he has written a paper that also says go low and slow, so you can trust him if you don't trust me. What is also important to say is you need to update your practice. So there's no point us having all this evidence and then never translating it into our practice. And I probably should have said at the start, I've worked as a clinical dietitian in the ICU for 18 years and as a dietitian for 20 years, and I still work clinically now. And so one of the most important things to me is any of the research that comes out or that we do, we need to then assess our practice and make sure we change what we're doing. So I just want to show you in 2017, this is what our guidelines said. Some of that starting stuff not so relevant to today, but we aim to meet energy and protein targets within 72 hours. And I can tell you that we regularly audit our practice, and within 72 hours, our patients would be at 80% of their nutrition requirements, because at the time, that was what the evidence was telling us. In 2022, we pulled right back, so there's been several studies published, and so we now start our patients on a protocol enteral feed when they come in. Our unit's very good at doing that. It's a basic concept of what happens. And we leave them at 40 mils an hour of a 1.25 kcal formula for up to 5 days. And we don't assess them, we just leave them on a protocol formula. Our unit is 65 beds, and I don't know, by your standards that's probably small, by our standards that's big. It's the largest ICU in Australia. We don't have capacity to see every single patient every day, and so this is also a way for us to triage our workflow and manage our time. We then assess the patients after that. We have a significant long stay population, so 20% of our patients stay more than 10 days, and really that's probably where we end up spending a lot of our time. In 2025, so we're just about to update this again, we are going to pull it back even further for patients that are on significant doses of inotropic support. We just haven't got to that, we haven't got to the final answer yet, but we're in the process of reviewing that. And so you'll see it come back even further. So what about long stay patients? This is a particular passion of mine in terms of long-term nutrition interventions. Nutrition is not a drug or a fluid. You are not going to give it for 2 days and think that you're going to change anything. That's not how it's going to work. And so we need to think about a long-term view. So what happens to these patients? Well, after 7 days, we're really in a black hole, and it likely depends on many things in terms of how we treat those patients, like pre-existing nutrition status, the severity of their illness, and pre-existing comorbidities. There's many other things you could consider.
You have one more minute.
Hello?
Sorry, this just got to start working. You have 1 more minute for the rest?
Sure, okay. I'm nearly finished, thank you. This figure I really like, as it really summarises nutrition and care across the phases, and I particularly like the post-ICU section. And so, again, this is opinion. We don't have a lot of evidence, but I really like what this group of authors are proposing in terms of how you might approach that phase. So just to summarise, less is more, but it's not nothing, and it should not be forever. So just really pay attention to that. And the other thing I just want to say is spare a thought for us doing nutrition research. Nutrition research is not easy. We have an outcome of interest over here, a causal soup of confounders in the middle, some sort of effect that we are desperately hoping to measure, and somehow we'll hopefully get some more answers for nutrition in the future. So thank you.
Thank you very much. With the next speaker, Dr. Yasin Al-Arabi. His talk will be about high protein versus standard protein for the critically ill. Does it really matter? Dr. Yasin Al-Arabi is honoring us today in this session. He is the chairman of the Intensive Care Department, Medical Director, Respiratory Services, Professor, College of Medicine, King Saud bin Abdulaziz University of Health Sciences, King Abdullah International Medical Research Center, and King Abdulaziz City, Riyadh, Kingdom of Saudi Arabia. Dr. Al-Arabi leadership has been recognized in multiple awards, including the Saudi University's Excellence Award in Scientific Productivity, and had well-established critical care trials regionally and globally. Dr. Yasin, welcome.
Thank you very much for this kind introduction and great presentation by Prof. Emma. So my presentation about more or less protein. Should we give more or should we give less?
Thank you.
I don't have any major conflict of interest except that I'm the PI on a PI-initiated trial called the Replenish that I'm going to touch quickly on. So what I'm going to talk about is the catabolic state during critical illness, how much protein our patients are getting now, and what's the optimal dose, and then go over recent interesting trials on protein in ICU patients. Now, when patients get very sick and come to the ICU, there are many changes in the body, try to overcome this critical illness. You have hormonal changes, your catecholamines go up, ACTH, and there are multiple inflammatory markers that go up, IL-6, TNF-alpha, etc. all these will lead to proteolysis. You start to break down your protein to generate free amino acids. These free amino acids will go to your liver, and the liver start to generate acute phase reactants that try to overcome the acute illness, generate immunoglobulin that are essential to get over the problem, and generate glucose also that is needed for energy. So we need to release some amino acids to get over the critical illness, but the price for this is heavy. You start to lose a lot of protein. So we have a significant catabolic state. And this leads to a negative nitrogen balance. And studies have shown that you lose a lot of your muscles. You lose maybe 13% in 1 week, 18% in 10 days during critical illness. And this negative nitrogen balance, or the catabolic state, leads to immunosuppression, poor wound healing, intensive care related weakness, and increased mortality and delayed recovery. So it makes sense then that maybe we should give protein, give additional protein, exogenous protein. So when we give exogenous protein, we make it available, amino acids make it available, so patients don't have to break down their own muscles. And on this basis, the clinical practice guidelines recommended that critical ill patients should give protein. And in fact, if you think about it, the WHO recommend people, healthy people, to get 0.7 to 0.8 gram per kg per day. What clinical practice guidelines recommend for ICU patients is almost triple this amount, as between 1.2 to 2.4, sometimes gram per kg. So we're recommending much higher amount of protein during critical illness to overcome this catabolic state. And this is based mainly on several observational studies. And as Emma mentioned, these observational studies have significant confounding effects. In my opinion, nutrition studies are really notorious for the confounding effects. You will see a huge treatment effect, but mainly related to confounding. And there are other observational studies actually showed that it's not the case. And maybe higher protein is associated with worse outcome. And this may be related to when you give too much protein for somebody who just came to the ICU on multiple pressors, ventilated, very sick. If you give them this, it may inhibit the autophagy, which is a mechanism in the cell to clear waste products, and it may increase the amount of production of urea, which is harmful. So we're going to go back one step, and how much our patients really getting of protein. This study from the International Nutrition Survey, they looked at how much, in general, patients in the ICU get protein. So the mean intake for patients who are staying in the ICU more than 4 days was 51 grams. So really, what we are giving is probably between 0.7 to 0.8 gram per kg. We're not really close to what the guidelines saying. And for those who are staying more than 12 days, and Emma mentioned the different phases of critical illness, they get a little bit higher than this, but not really that high. So 57 grams, so about probably 0.8 gram per kg. So what's the optimal dose? This is a meta-analysis of multiple studies. This was published several years ago of the multiple studies on protein, high versus low amount of protein. And in these studies, the lower protein group received 0.9 gram per kg versus the high protein received 1.3 gram per kg and did not find any difference in mortality. There are small studies that looked at muscle loss, and they found that if you give more protein, you probably have less muscle loss, but it's a small group of studies. We have better evidence that I'm going to share with you in a second. And in fact, there are studies based post hoc analysis from the EPANIC trial. And if you remember the EPANIC trial, a trial randomized patients to early parenteral nutrition versus parenteral nutrition start on day 8 and after. And this trial showed that if you give early parenteral nutrition, you delay recovery from ICU. And when they did post hoc analysis, they found that mainly this harmful effect was related to protein, not even to energy. So it looks like it's related to protein. They did a CT scan study on patients who received early parental nutrition or delayed parental nutrition, and you would think that if we give more nutrition early, you build muscles. Well, they couldn't find this. The muscle mass was the same. They had more fat. So early giving more parental nutrition early doesn't build your muscles, okay, based on this CT scan study. It gives you more fat. This is a post hoc analysis from the permissive underfeeding, where we looked at association of high protein versus low protein with the outcomes based on nutritional status and assessed by the Nutric score. So low Nutric score are the patients who have low nutritional risk, and the high Nutric score are the patients who have high nutritional score. And in both groups, there was no association with mortality. Maybe you could say that adjusted odds ratio 0.6 suggests maybe an effect possible in high Nutric score, but that was not statistically significant, as you see from the confidence intervals. But what we saw in patients who are getting more protein, that they excrete more in their urine. So basically, you give it in the gut, they lose it in the urine. So, we think that if we give protein, the body gonna retain it and build muscles. We're not sure. It looks like the body also catabolize it and excrete a lot of it in the urine. And so no surprise with all this evidence that is all over the place, the guidelines give you wide variety of ranges for protein. And what's interesting, if you look at the right side, what's the quality of evidence? Very low expert consensus, very low expert consensus, etc. So it's really based on what we think, our interpretation of the data thus far. Emma mentioned that the use of maybe more objective measurements to guide protein. Maybe we should measure protein nitrogen balance, and based on the nitrogen balance, we can guide the amount of protein. This was tested in a clinical trial where patients randomized to receive nutrition based on assessment by indirect calorimetry and 24-hour urinary urea. And the control was based on fixed formula based on ESPEN guidelines. And indeed, patients who are in the early goal-directed nutrition did get more energy and did get more protein. That's for sure. But there was no difference in the primary outcome of functional status or any difference in mortality. Protein timing is essential. So there are arguments, people say, once a patient comes to ICU, we should give them a lot of protein because this is where the catabolic status starts. So we should give them a lot of protein so we can increase muscle synthesis, especially protein is easily absorbed, and we could give it IV, also we could give IV amino acid. But the opponents of this opinion will say that maybe that's not really a good idea because it will increase the production of urea. We don't have a strong evidence that giving exogenous protein will increase your muscle mass. Giving too much protein increase glucagon release and inhibit autophagy. So we're not sure. Recent trials, the EFFORT trial was published in 2023. It's a big trial, was planned to include 4,000 patients and randomized patients to receive 2.2 gram or more versus less than 1.2 gram per kg as early as possible. So we're talking about early protein from ICU admission. The primary outcome was 60-day mortality. This was changed during the study because of COVID-19 and slow recruitment to time to discharge alive. And the sample size was also changed to around 300 patients. The trial did not show a difference in the primary outcome. So there was no difference in the time to discharge alive. There was no difference in secondary outcome of 60-day mortality or any of the other outcomes. So high protein versus lower protein early on in critical illness in this study did not show a difference. When they looked at subgroups, and you have to keep it in context, this is subgroups, they found that patients who had AKI on admission did better if they received usual care, if they received moderate amount of protein, not the high amount of protein. The high amount of protein did worse. SOFA, severity of illness, patients who were sicker also did better when they received less protein, not more protein, less protein. This is really, was big news, really. And when they looked at mortality, it's the same. This one had an implication for our trial that I'm going to mention in a second. So there, more recently, the PRECISE trial. This trial included 935 patients, randomized also to high protein versus lower protein. So basically, the study, they gave formula that is standard amount protein versus rich with protein. And they started from day 1, gradually increased to the goal by day 4, and they looked at functional outcomes as a primary endpoint. Now, this study is a really important study. They included in the standard protein 465 and high protein 470. One thing to keep in mind, there were a lot of loss of follow-up. It's really important to notice this. Not unusual in patients who need follow-up after discharge, but it's something to keep in mind when you interpret these results. So out of 465, there were 430 that had the primary outcome, and out of 470, there were 419 had the primary outcome. There was difference. There was statistically significant difference, but this difference favored lower protein. Lower protein did better, slightly. I mean, this difference in the utility score is minus 0.05, it's really small. So whether it's clinically relevant or not, that's a different question. But I think you could say that based on the study, higher protein did not lead to better functional status. Mortality, not statistically significant, but if anything, really favors the standard protein. Again, this is about early protein. They looked at multiple other functional outcomes, but I think we need to take them with a lot of care because the number of loss of follow-up is just tremendous. It's like this, these outcomes are available for probably less than 50% of the patients. But what's interesting here when they looked at subgroup analysis, that they couldn't see the same thing seen in the EFFORT trial. So the AKI, acute kidney injury, there was no, this differential effect that we've seen in the EFFORT is not seen here. The severity of illness, based on SOFA and based on Apache, this huge differential effect that was seen in EFFORT was not seen here. So putting a question mark about whether really there's differential effect by severity or AKI and really need further elaboration. The Nutria trial, Nutria 3, this is a trial done in patients with shock and acute respiratory failure. These are intubated patients on pressors, started on early, day 1, full enteral nutrition versus reduced nutrition. So calories and protein were reduced. They couldn't find difference in 90-day mortality, but the median time for ICU discharge was shorter in the less feeding, and there were less vomiting, less bowel ischemia, less liver dysfunction when you give less feeding early. So collectively, all these studies tells you that maybe early on, day 1, don't push too much feeding, okay? The previous guidelines said, day 1, we should give full, we give a lot of feed, even when the patient starts to get the feeding out of his nose, should give him feed. No, these studies tell you, no, not early on, you don't have to push very hard. We are conducting a trial called the Replenish, and this trial for high protein versus low protein, but this study was designed not for early feeding, for kind of the recovery phase, starting the high versus low protein on day 5. So first 4 days, patient receive whatever he gets, but on day 5, patients will start on the higher versus lower amount of protein. And the primary outcome is 90-day mortality. Recruiting in 18 sites. We're really pleased with all our colleagues from Saudi Arabia and from Kuwait. Really big thanks. Dr. Walid is one of our helping us with this. Dr. Abdurrahman and Dr. Sarah, fantastic work. We have 2,000 patients enrolled in the study. It's really the largest study so far. 500 to go. And this is what we achieved. So early, you could see here the first 4 days is patients get whatever they get by their treating teams, but the separation starts on day 5. And as Emma mentioned, of course, patients at the end will need some nutrition because they have to recover, right? I mean, they lost muscles, they have to build it back. Eventually, we want them to go back to where they were before they got ill. So hopefully, we'll have some answers. So when the effort trial was published, we panicked, okay? And we had to conduct an additional interim analysis, detailed in humanities by the DSMB, looking for the patients with AKI and the patients with high versus low severity of illness. And then after detailed analysis, they assured us that we should carry on with our protocol as planned. So we are. So in conclusion, critical illness is associated with proteolysis and negative nitrogen balance. I think we all agree on this. Current practice guidelines recommend that we give protein more than healthy individuals. Many ICU patients don't get what's the recommendation, say generally. Whether this is good or bad, I don't know. But I think we have a reasonable amount of evidence that maybe we shouldn't push too much in the first few days. Maybe the answer in the later phases, maybe after day 5 or later. I think we need more studies, but this is really exciting area for future studies. Thank you very much.
Thank you, Dr. Yassin, for that excellent talk. We shall now move on to our next speaker, Dr. Walid Al-Hizani, who is the Director of the Health Research Center at the General Administration of Health Services of the Ministry of Defense of Saudi Arabia, and is one of the most renowned critical care physicians and researchers in his field. Thank you. And he'll be giving a talk on,
Thank you for the kind introduction. I just need my slides to be shown, please.
Yeah, I forgot what.
This one? Yes. Yes. Thank you very much.
Not the talk.
Can we display it on the screen, please?
It's not this one.
It's the wrong talk.
Okay, wrong slides, my friend.
Oh boy.
This is what happens when you get older. You can't see really small fonts. So, okay, I think we got it now. Okay, try now, please. Excellent. Well, it's a great pleasure to be here today. This is my first visit to Kuwait, although I have a lot of friends here. Also, ironically, it's the worst time to present about gastric residual volumes because I got sick yesterday and was suffering from nausea, and I believe my GRVs were through the roof. But luckily, I had some domperidone with me. So that's my first conflict of interest for today's talk. Other conflict of interest that I have, all are intellectual. I've been an author on the ESPN guidelines. I authored relevant papers on the topic. And I'm also a co-investigator on the Patients Research Program, which I'm going to touch base on briefly. Hopefully, by the end of this talk, we will learn about the normal and abnormal physiology of gastric motility. We'll review the evidence on measuring the gastric residual volumes in the ICU and what interventions that we have and the evidence that supports it. I usually tend to get over time. I get carried out with my presentation, so I would appreciate a 5 minutes notice so I can stay on track. I always like to know my audience, so who are in the audience physicians, trainees or consultants in the ICU? Okay. Who are nurses? Very few. I suspect dietitians will be more. Who are dietitians? Yeah, there we go. Mostly are dietitians. Excellent. Well, hopefully this will be worthwhile your time. So the normal gastric motility involves the pacemaker cells of the GI tract, which are called interstitial cells of Cajal, or we'll refer to them as ICC. These are the pacemaker cells that generate electrical impulse and controls the slow waves throughout the GI tract. And believe it or not, there is such an electrogastrogram similar to the ECG, and there are conditions where the motility is reduced, which we call bradygastria if you have less than 3 cycles per minute, or tachygastria when you have an overactive GI tract. And hopefully the audio visual will work. I'm just going to show you an endoscopic image. Let's see. I was told to click on it twice. And it's not working, audio visual. Okay, let's try again. Well, this is supposed to show you an endoscopic view of the stomach where you see a small peristalsis moving towards the antrum of the stomach. But if you look carefully at the ICCs, they are controlled by neurohormonal balance in normal situations. For instance, what activates the ICC and increases the motility of the GI tract is a parasympathetic activation. People who are sick in the ICU, usually they have a sympathetic overdrive, therefore it reduces the activity of the ICC. Motilin, which is a substance that works on the motilin receptor and probably the strongest motility agent that you will see. Ghrelin and serotonin as well, they all activate motility in the GI tract. And on the other hand, a sympathetic overdrive, nitric oxide, inflammatory cytokines like IL-6, TNF-alpha, all can reduce the activity of the ICC, hence reduces the GI function. Those of us who fast whether in Ramadan or do intermittent fasting, when you hear that gurgling sound in your stomach, this is the MMC. And the MMC, or the migrating motor complex, is divided into 3 phases and is controlled by the ghrelin and the motilin receptors. As you can see, it's one of the produces the strongest contractions in phase 3 during fasting, and during normal eating hours, it goes back again to normal peristalsis in the stomach. So this is what we call the migrating motor complex, the housekeeper. Its function is to sweep the GI tract, but it's also affected during critical illness because it's mostly related to motilin and autonomic nervous system. So really a lot of changes happen during critical illness. In the esophagus, you may have reduced peristalsis, dysfunction in the lower esophageal sphincter. In the stomach, there is delayed gastric emptying, especially antral hypomotility, which is very sensitive to motilin. And small bowels, you will have reduced or disrupted MMC. And as we know, in the colon, you may have a functional obstruction, or what we call Ogilvie's syndrome, that can happen with any acute stressful condition. And this slide just summarizes the intrinsic and extrinsic factors. Many things we do in the ICU could affect the patient's GI motility, including the medications, vasopressors, sedation, opioids, hyperglycemia, name it. Many things we do in the ICU could affect it. In addition, mechanical ventilation may reduce the perfusion of the GI tract, gut ischemia from being hypotensive. So many things could go wrong. This is why we see many patients in the ICU not tolerating feeds. The problem is how we define feeding intolerance. Many of us use gastric residual volumes, but we'll talk about that in a second. However, people may use different thresholds, so vomiting or aspiration of gastric contents, abdominal distension, or as I said, by measuring GRVs, whether technically by aspirating the stomach or using ultrasound to quantify it. A recent systematic review of prognostic studies have been published looking at risk factors, and I ordered them for you chronologically from the strongest to the lowest association. So as you can see, not surprisingly, being sick with the high Apache score is associated with higher odds of developing feeding intolerance, higher intra-abdominal pressure, delayed enteral nutrition, extremes of age, hypervolemia, hyperglycemia, hypokalemia, and the list goes on, and the association goes lower as you go down this table. So to make sure that people are engaged, also for my own interest, I'm going to ask you guys, what GRV threshold do you use in practice? A, raise your hand if you don't care about GRVs. Okay, a few people. Also the chairs and speakers. Okay. Do you use a threshold of more than 200 or 250? Also, very few. Do you use a threshold of more than 500 mils? I think the majority goes there. Anybody uses a threshold more than a liter? No one. Well, we did ask the same question. Again, credit to my colleagues in Denmark who conducted a survey, and I got permission to share the results. It's not published yet. They surveyed more than 830 doctors in 17 countries, and the majority, around 70%, use a threshold of 500, and the quarter of respondents uses a threshold of 200. Similarly, in the UK, majority of people use the threshold of 400 to 500. And this tells you that GRV is a diagnostic test. So whatever you set the threshold, your sensitivity, specificity changes. So on lower threshold, you may increase the risk of false positives, so including patients, assuming more patients to have feeding intolerance while they don't have it. And when you make a very tight threshold, you may miss some cases on the expense of being more accurate. Okay, I'm sorry about the slide not aligning very well, but again, another question. In your opinion, does monitoring GRV improve patient outcomes? Yes? No? Okay, definitive no? Or we don't know? Okay, great, excellent. So very few chose yes, some chose no, majority, we don't know. We're all familiar with the JAMA paper that the RCT that randomized patients who were mechanically ventilated for 2 days or more and received enteral nutrition to either not measuring GRV or routinely measuring GRV every 6 hours. It's a multi-center study that was done in France, and this was the conclusion of the authors. The absence of GRV was not inferior to routine residual gastric volume monitoring, and everybody started avoiding measuring GRVs. When you look carefully at the results, and hopefully, okay, let me see if I can, or maybe I'll use the pointer if it works. Anyways, so this is the display of the results in the absolute scale. So in the middle is the line of no difference, and I'm showing you the results. The point estimate suggests that not measuring GRV may slightly increase risk of VAP, and this is the upper limit of the confidence interval at 0.67. Remember, the trial was designed as an non-inferiority trial. So I'm going to ask you a more technically challenging question. Assuming that the rate of VAP in your institution is 10%, so 10% of mechanically ventilated patients will develop VAP, how much increase above this 10% would you accept and still okay with not measuring gastric residual volumes? For instance, if you say 1 to 2, so you would accept an increase up to 12%, a total rate of 12%, and you still say that's acceptable, I'm not going to measure GRV. Clear? Okay. Who think 1 to 2% is reasonable? Okay, many. Who think 3 to 5% is still acceptable? Okay. Who think that 5 to 7% increase in VAP is acceptable? Nobody? Okay. Who think 8 to 10% is acceptable? Okay, so majority were okay with 1 to 2, some with 3 to 5, but none was okay with 5 to 7. Well, as it turns out, authors of the trial, they used a non-inferiority margin of 7%. So they were okay, by definition of the question, to label not measuring GRV as non-inferior if the pneumonia rate goes up by 7% from baseline. So if our baseline is 10%, we're still okay if it goes up to 17%. So that's something to keep in mind when you interpret the results, and the upper limit of the confidence interval was pretty close to the non-inferiority margin. When they looked at other clinical outcomes, including vomiting, there was an increase in vomiting, but also logically less interruption of feeds and no difference in ICU-acquired infections. Colleagues summarized the evidence on not measuring GRV in a meta-analysis, and again, the effect on VAP, although very small studies, very small event rates, is sitting in the middle, showing no difference. The effect on other clinically important outcomes like effect in feeding intolerance. It seems that not measuring GRVs resulted in less feeding intolerance, obviously less interruptions of feeds, but resulted also, on the other hand, in more vomiting and had no effect on mortality. So unfortunately, this is all the evidence that we have when it comes to clinical trials testing GRV in clinical practice. So what does that say? As you rightly predicted, the effect of routine measurement of GRV and patient-important outcomes is still unclear. However, you could say low-quality evidence suggesting less interruption of feeds on the expense of increased risk of vomiting, but I think bigger trials may be needed to help guide practice. What do the guidelines say? They were not super clear. I'm also author on the 2019 version of the guideline. I did not author the recent update, but GRV may help identify intolerance in enteral nutrition patients. If, as you also rightly picked, a GRV threshold is above 500, then you may consider that as a sign of feeding intolerance, but we'll talk about that in a second. So what do you do? This is my general approach. Any patient with suspected feeding intolerance, if your ICU, and I should have asked you how many of you measure it routinely, because you guys seem not to believe in GRVs, but still many ICUs use it routinely. If you have a suspected feeding intolerance, always go and assess the patient, always. Examine the patient, because you need to understand if there is any clinical signs of obstruction or functional or mechanical obstruction. I'm not sure what's happening. Look for any reversible causes and try to correct them, hypokalemia, hyperglycemia, etc., medications. And then you can start with pharmacological therapy or consider other approaches. But I think the key step is always to examine the patient, because an isolated increased gastric residual volume by itself may or may not mean anything, but your pretest probability will immediately go up if there are other signs like vomiting, abdominal distension, etc. Several prokinetic agents are available, acting on different pathways. D2 receptor antagonists like metoclopramide, which can be used IV or oral, domperidone, which is used only orally, other agents like motiline receptor agonist, erythromycin, and newly other medications that are still under study, and also serotonin receptor agonist, cisapride, has been pulled from the market due to sudden cardiac death. The main issues, as you all know, is cardiac side effect, and for some is tachyphylaxis, which means you lose the effect as you get exposed to the medication. Colleagues in Denmark, which I helped them author this scoping review, they looked at all clinical trials examining prokinetic agents for hospitalized patients, not only in the ICU, but hospitalized patients. And most studied medications were macrolides and metoclopramide, but there are few studies in the pipeline coming for newer agents. So maybe in the next few years, you'll see newer agents acting like ghrelin agonists and other motiline agonists as well coming through the pipeline.
5 minutes left.
Thank you. When it comes to the efficacy of the medications, we conducted a while ago, and there hasn't been a lot of studies published since then, systematic review meta-analysis, looking at the efficacy and safety of these agents in the ICU. And if you look at these forest plots, there is, let's say, low to moderate quality evidence suggesting it may reduce feeding intolerance, so using prokinetic versus not using it. When you look at the agents, only one study looked at metoclopramide. Most of the studies looked at erythromycin. Hence, the guidelines translate. Oh, what's happening? My slides are not moving. I've been talking for like 10 minutes. Hello? It's working here? These poor guys can't see my slides. You should have said something. You give me more time.
Sure.
It's moving on the screen here.
No, no, no.
Projector is frozen somehow. Oh, okay.
It's always fun to have these technical challenges. Just adds a little bit to the presentation. Still not working.
Stand around the screen here.
Not working. Okay, to keep you guys engaged, how many of you routinely measure GRV in the ICU as part of the protocol? Oh. How many don't have GRVs mandated in the ICU? No, there are many people who didn't vote, and the rest are just they don't know, probably, because I think it's split 50-50. So two options: either you have to rely on your imagination as I speak, or IT can help us figure out what's the problem. Alhamdulillah. Good. Now we can go back. Okay, I'll try to be super quick. So we spoke about the approach. I mentioned a few prokinetic agents. I also told you about the scoping review and that it's studied most commonly erythromycin, metoclopramide, and other medications that are coming through the pipeline. And I also mentioned our meta-analysis that showed prokinetic agents reduce the risk of feeding intolerance. And when we looked at subgroup analyses, and again, it's very few studies, so it cannot tell you much, that erythromycin was the most effective agent. This is why the guidelines suggest erythromycin should be used as first line. They also reduce high gastric residual volumes. If you look at the ESPN guidelines, the older and the newer version both suggest or recommend, whatever language you want to use, using IV erythromycin as the first line of therapy, but they also acknowledge that the evidence base is not that strong. And they advise using IV metoclopramide as a second line agent or a combination of both. If you use a combination, be wary about the side effect. They also mention to use it for about 3 days and then stop. Well, disappointing to see the evidence base to be that low, but don't be too much disappointed. Our colleagues in Denmark, Morten Highlander Muller and Vera Kron, are leading a research program called Patients that hopefully will answer some of those pertinent questions. The Patients Research Program already completed an international survey that I showed you, a systematic and a scoping review. Also, we're at the very last days of finishing a large multi-center international cohort study, which Kuwait is also was part of. The next step would be to design a larger RCT and hopefully quick translation into clinical practice guidelines, so stay tuned. So what if medications don't work? There are other options that you can use related to the mode of delivery. Most of our patients are receiving gastric feeds, but there are small bowel feeding tubes or post-pyloric feeding tubes. Depending on the length, you can reach certain parts of the small bowel. The placement of these tubes could be done just by positioning a prokinetic at the bedside, or could be used if you have a fancy external guiding device on fluoroscopy, or if you're a gastroenterologist like myself, you can use endoscopy as well to place them. There are also newer fancy devices that allows direct visualization. Only few studies have been done, but successful case series of successful placement using these video-guided insertion of small bowel feeding tube. So what's the evidence behind it? Years ago, we published a systematic review summarizing all clinical trials looking at the utility of post-pyloric feeding versus gastric feeding. And it seems that low-quality evidence, and I say low quality despite multiple studies, because they all were small sample size, reduction in pneumonia, perhaps reduction in ventilator-associated pneumonia, with no effect on mortality at all, but also noticed that the use of prokinetic during insertion of those feeding tube significantly enhance the success of placing them. Who knows, maybe in the near future, so as a gastroenterologist, we've seen patients with severe gastroparesis who require gastric pacemakers. There may be some electrical stimulation devices could be used cutaneously in the pipeline, but still under investigation. And the ESPN guidelines, the most recent guidelines, suggest the following. So in patients who are deemed to be high risk for aspiration, and depending how you define high risk, post-pyloric feeding tube, especially jejunal feeding tube, can be used. Again, low quality evidence. They also suggest that gastric access should be the mainstay, so we shouldn't just haphazardly put patients on small bowel feeding tube just because we can't. And that if you are not tolerant to gastric feeding tube, start with medications and then proceed with post-pyloric feeding tube. So this was my last slide. Hopefully we've learned today, if you still remember after this technical interruption, that the normal physiology of the GI tract is dependent on the ICC and the MMC. The value of gastric residual volumes in the ICU is uncertain, obviously, depending on the threshold that you use. And always examine your patient and just don't rely on just gastric residual volumes. For pharmacotherapy, you can start with erythromycin. You also can start with metoclopramide as well, but the guidelines suggest erythromycin and metoclopramide. Consider post-pyloric feeding tube in patients who have resistance to medications, and TPN is the last resort, except if the patient is really malnourished and they need nutritional support, then you don't have much time. Thank you very much.
Thank you very much, Dr. Walid. With our next talk, it will be about innovations in the management of liver failure in ICU. Do we need a liver intensive care unit? With Professor George Ozenberg, Ozenger. Professor Ozenger, he's the chair of the Department of Critical Care at Cleveland Clinic London, consultant and reader in intensive care medicine with King College London, and former clinical director for critical care at King's College Hospital NHS Foundation Trust. He has 24 years experience of working as a consultant in the NHS. He was the lead clinician for the liver ICU from 2007 until 2015, also probably the mastermind of the extracorporeal life support. When he became clinical director for critical care at King's, a position he held until 2019 when joining Cleveland Clinic in London. We are honored to have you here today, and we hope we benefit from this coming talk. Thank you.
Shukran Salah and Anwar for the invite to beautiful Kuwait, and the take-home message is to keep one's biography always very short. So it's a pleasure to be here and talk a little bit about, I guess, the second part of this presentation, do we need a liver ICU? The answer is yes, obviously, I would say that. Going down. So, liver failure is, I think for all of you, a fairly common disease. So quite a lot of patients potentially ending up on ICU with a failing liver. But acute liver failure is very, very rare, as you will see in a subsequent slide. So a little bit about pathophysiology there, what happens if the liver is not working, detoxifying function cease, toxic plasma which hinders hepatic regeneration, and the problem we all are very familiar with of patients ultimately dying of mainly infections and multiple organ failure. But although phenotypically patients may look all quite similar, and often they are quite unpopular on the ICU, there are quite a lot of very distinct disease processes at work. ACLF is something which is relatively new. So we've in the past always talked about decompensated liver disease or cirrhosis, but this is just to show that the time course of disease and outcomes in patients who have got an acute decompensation, predominantly relating to bleeding or infection and end up with organ failure, and the terminology for that would be acute and chronic liver failure, do exceptionally bad when in ITU. Pathophysiologically, often inflammation-driven, and you see a few pointers there in terms of damage-associated molecular patterns and pathogens-associated molecular patterns being triggered by usually inflammation or infection problems, and a high mortality and getting higher as more and more organs are failing. And unfortunately, a lot of what we've tried to do with these patients, including extracorporeal device therapy, seems to have little effect, and the only solution is potentially liver transplantation, and a little bit more on that later. Just to point out what I've just said in terms of organ failure, so you see here 28 and 90-day mortality rates for patients with acute and chronic liver failure if no organs fail, versus an increasing number of organs fail. And as you can see, at 90 days, the majority of patients with 2 to 3 organ failure, unfortunately, die. ALF, a very different disease entity. So by definition, no previously known and underlying liver disease. And it usually is really typified by patients who, after decompensation and having symptoms of de novo liver disease, predominantly jaundice, end up being encephalopathic. It is a very rare disease, and if not treated, has got a fairly high mortality. One of the advantages, as opposed to acute and chronic liver failure with organ failure in association with it, is, however, that there is quite a significant ability of the liver to regenerate. The problem is, it's not only rare, but also in terms of its etiology, very different and heterogeneous across countries, continents, which makes studying it very difficult indeed. It is probably quite important to subclassify acute liver failure, and you see the various columns here of hyperacute, acute, and subacute. The classification is predominantly driven by the time of first symptoms to the onset of encephalopathy. The reason why that is important is because A, it may give you a pointer towards etiology, and you see sort of typical presentations for hyperacute. For us in the UK, it is predominantly acetaminophen or paracetamol driven, but also hypoxic hepatitis, for example, cardiogenic reasons, versus acute, so a slightly longer interval between patients becoming symptomatic and encephalopathy, predominantly viral diseases, and subacute, most often seen with medication-related liver failure, such as anti-epileptic medication, anti-tuberculous medication, for example. The other importance is the clinical presentation, where for hyperacute liver failure, patients are often very dramatically ill with multi-organ failure, very metabolically deranged, often have got significant intracranial hypertension, their outcome and their capability of regenerating is actually quite significant. And by now, we see transplant-free survivals in this group of up to 60–70% at times. Whereas subacute, you've got a patient who had symptoms for months and now they go encephalopathic, meaning that their liver is really at the end of its tether and their chance of surviving without a transplant is virtually zero. Clinical features, well, pretty much any organ can be affected, as you can see on that sketch on the right-hand side. Most of the time, once we see patients, it's a multi-system involvement. Sometimes we see extremes of toxic liver syndrome, whereby the necrotic liver cells cause a lot of systemic mayhem. And sometimes we even have to take the liver out and do a portocaval shunt procedure, hepatectomize the patient to keep them alive until we potentially can get a transplant organ. What follows from that is that it demands timely management, early diagnostics, and aggressive therapy to make patients survive. And I guess that is one of the arguments for having these patients who have a quite rare occurrence in a specialist unit, which can see many of them over a period of time. As always, creation of centers of excellence of that kind depend on people. And Professor Roger Williams there 50 years ago basically founded the Institute of Liver Studies and started really researching into acute liver failure. Most of you, I presume, know my precious colleague, friend, and peer, Julia Wendon, who I guess has sort of really made a name for liver critical care across the world. So I didn't work then at King's. That's about probably 50 years ago, as you can see by the type of the cars you see. But I've sort of been there almost, as you can see on the left-hand side, the old beginnings, or maybe 10 years later, with a very old infrastructure and 2 rooms of 4 or 5 beds where we were treating these patients. Clearly the equipment by then was a little bit more modern. We've now moved into, by now, obsolete department and area on the top right-hand corner, and there's a new critical care center which is really state-of-the-art, but because of bed pressures, and although we've now got 95 beds, we've remained in our now 20-year plus old unit. Bit of background in terms of King's. So lots of transplants being performed over the last 40 years, as you can see there, and still we do about 200 to 250 adult and pediatric transplants combined per year. Well, you know, there's lots of centers nowadays, especially with living donor liver transplant, that do more, but it's still one of the largest centers in Europe and the UK, and we've got a dedicated specialist liver ICU with lots of things being done, as you can see on that graph, or not see because it's very small print, also in terms of creating evidence base and moving things forward in terms of liver research. What do we do? Well, we've got a fairly broad portfolio in looking after patients perioperatively around transplantation, see patients obviously with ACLF, but also hepatobiliary surgery, and predominantly, obviously, still our bread and butter is acute liver failure. It's clearly not only the intensivists, it's the team, the multidisciplinary team, as you can see there, and people who then potentially work as attendings or consultants, and we've got a fairly small group of colleagues, would have been undertaking fellowships prior to starting with us. Usually people have got quite a wide range of competencies, as you can see there, which goes into neurocritical care, I guess, cardiovascular critical care, as well as radiology and interpretation, knowledge about immunosuppression. And we do also provide a fairly comprehensive assessment of patients, as you can see here, with right heart catheter studies, referrals in relation to ECMO and liver transplant. And it's a very well-functioning MDT with multiple touch points, as you will see in a moment. So we do lots of meeting together and discussing, not only within meetings, but also on the corridors and within our rooms, I guess. And what comes with that is not only an experience and interest, but expertise and innovation through being inquisitive, doing research and being academically active, and then creating networks with like-minded colleagues, not only regionally, but also nationally and internationally. And one of the main important things also is to support the referrers. As you can see on this slide, we get quite a lot of calls on a day-to-day basis regarding predominantly around advice and potential diagnosis and treatment, and forget about criteria in terms of when we would potentially move patients to come to King's, but a lot of it happens remotely to start off with treatment advice before we would potentially triage and decide to take patients, because many patients actually can be managed locally. I've mentioned MDT networking, and you see a little bit of a busy diary, but this is sort of what the week looks like with lots of meetings. And I stress the 4 o'clock meeting, which is really very important, where the intensivist, the transplant hepatologist, transplant surgeon comes along, and we talk not only about the transplanted patients, but about every patient on the unit in essence. And it's a really important exchange of ideas as well as expertise. I talked about radiology skills, and this is what we also do, especially when we talk to referrers. For example, here you see some of the blood parameters, a patient with a typical presentation of subacute liver failure, sequential scanning showing shrinking of the liver, which, you know, to the lay eye may be more perceived as cirrhosis, but in fact this patient had subacute liver failure. Whereas the IVC, what I'm meaning by that is this patient has got Budd-Chiari syndrome, a very large congested liver, with no venous outflow. The caudate lobe is quite big. You can't see the IVC, although you should see it on the contrast because it's compressed by the caudate lobe, and some numbers which can go with that. Think laterally for the eagle-eyed of you and looking at the hemodynamic parameters predominantly. Clearly there's something not quite right. The patient is shocked, and as you can probably see on this contrast scan, that there is some stuff in the central PA. So this patient obviously didn't have a acute liver problem to start off with, but a secondary liver problem due to a right heart failure, cardiogenic shock, and massive PE. So the treatment course probably will need to be fairly different. Call the family why? Another big liver which looks very heterogeneous. You can't see any portal vein. The reason being is it's infiltrated by tumor thrombus. This is a situation, one of the rare situations where we would potentially think about a biopsy, transjugular biopsy, TJB, because it would inform what to do. These patients usually are not candidates for a transplant. Even if you looked at the blood parameters, they would sort of fall into a category where we would think about transplanting the patient. Point of care ultrasound, I guess, you know, lots of you are very familiar with that, and clearly it is something we do on a regular basis, as you can see there, not only obviously for line insertions, but also transcranial Dopplers as well as abdominal ultrasound. The heart, deep transgastric views on TOE in somebody who has got portopulmonary hypertension. You can see a PA catheter floating around in the right ventricle, which is rather hypertrophied, functioning at this stage pretty well. So this patient was relatively early maybe in their disease with very high, almost suprasystemic pulmonary artery pressures, but still a well-functioning RV, as opposed to the other patient here, where the RV clearly is not working well indeed, mid-esophageal four-chamber view. Patient coming back after transplant with no blood pressure, on huge amounts of vasopressor agents, primary non-function, the lungs are not great. What do you do? Well, again, it looks as though there is a bit of a cardiac problem. Heart seems to be contracting reasonably well. Maybe the basal septum not that great, but what you can see is that the anterior mitral valve leaflet seems to be flipping into the left ventricular outflow tract. So this patient has actually got functional left ventricular outflow tract obstruction and SAM, which needs clearly quite different treatment to somebody who's got a non-functioning LV in terms of choice of inotropes or minimal inotropes, vasopressors, filling if possible. In this situation, unfortunately, a patient had severe ARDS, so they ended up on extracorporeal support and needed relisting for transplantation. We sometimes become neurosurgeons. Walid talked about his eyesight. Well, my eyesight pretty poor there as well, but because our neurosurgeons refuse to put in intracranial pressure monitors, we do it ourselves. You see a bit of a protocol what we do, which is fairly pragmatic. We give them FFP and some cryo and maybe platelets, and off we go. This is a series of 115 patients. Quite a lot of them had high intracranial pressure. Well, surprise, surprise, they were identified already a priori as potentially being at risk. But at the bottom, relatively low complication rate, as you can see. And again, on the top graph, this was a patient who actually did very well, had the kitchen sink thrown at them in terms of brain protective measures, including barbiturates. The lavender-colored 31 trace, a very high P2, so poorly compliant brain, very high pressure, which with treatment improved on the bottom graph. So what we learn from that is maybe that patients who've got liver failure are not always bleeding dramatically. They can, but there is also patients who don't because there is a balance in the hemostasis. What happens, however, is on the right-hand side, that this balance can be easily brought out of kilter. And patients can bleed as well as have clots. It's a very nice review paper from Beverly Hunt, if you're interested in New England Journal of Medicine, which explains a little bit the background of that, but obviously anticoagulant as well as procoagulant proteins not being produced by the failing liver anymore. So, what also follows is research and evidence generation. Just a few or two quick slides in terms of trials we've certainly participated in and contributed to in a majority fashion in the last 20 years. Hypertonic saline, you see here mentioned in patients who've got cerebral edema. Here, high volume plasmapheresis and hypothermia for acute liver failure. The only trial which has ever really shown any difference in acute liver failure is plasmapheresis therapy. I think I've got another 5 minutes, is that right? Yeah? Extracorporeal therapies, well, there's lots of talks about renal replacement therapy and delay or not at all, and wait, and later is better than earlier. Well, maybe in liver disease it isn't, and the reason being is that it provides quite a lot of metabolic control, especially if we do it at very high volume, if we want to bridge a patient to a transplant where the organ is sort of on the horizon, but also in relation to onset of cerebral edema and intracranial hypertension, because temperature control reduces ammonia production, which is one of the key drivers for cerebral edema. And with increasing effluent rate, we can actually decrease ammonia as well, as you can see here on this nice, quite linear graph, dependent on effluent rate on the bottom. Basic research. So we've done a lot on monocytes and macrophages. And sorry, this is quite a busy slide, but monocytes and macrophages are quite pleiotropic cells. And on the left-hand side, you can see how the damaged liver cell will trigger lots of different responses. We talked about DAMPs and PAMPs, toll-like receptors, which will get triggered and really release inflammatory cytokines, which then are responsible for formation of cerebral edema, vasodilatation, bad effect on the gut-brain-liver axis at the top. But later on, those sort of same cells who've transformed into type 2 kind of M2 cells are very important for hepatic regeneration. The reason I'm mentioning this is because what we can do and what we try and do, and that is sort of the pathophysiological basis for it, is exchange plasma early on to have an effect on this very early hyperinflammatory response. But if you did that late, during the more anti-inflammatory cycle, you may actually do more harm than good. So this was the basis for the only trial which really has shown a difference in acute liver failure, which is high volume plasmapheresis in ALF. Big volumes being exchanged, as you can see here. Fresh flows in plasma only, and the majority of these patients were paracetamol-induced acute liver failure, and many of them were acute rather than acute. And important, I guess, the bottom graph, which shows an improvement in transplant-free survival. So
2 minutes.
About 68 patients did not get transplanted, and they had a better outcome, as you can see, at relatively low cost. But one should also think on the right-hand side about other problems it brings with it, the logistics, the huge volumes exchanged, confounding of diagnostic tests, and removing things we may quite want to have, such as antimicrobials. And this is the real-life experience to it. Much lower volumes nowadays used, and this is a follow-up observational retrospective data analysis in the UK across all centres. And about a third of patients were in this subset out of 378, I think, plasmapheresed. Improvement in hemodynamics, but no survival and outcome benefit. Mind you, a not controlled trial. Talked about ACLF earlier, so very brief mentioning of this and the lack of any therapies. So this is actually a very important trial my colleague Will has published this year, end of last year. A prospective national program whereby ACLF patients with organ failure get prioritized on the transplant list, a bit like acute liver failure. You see the exclusion criteria on the right-hand graph. And this is the very important Kaplan-Meier, I guess. So out of 52 patients during this early phase of prospective investigation, 10 patients did not get transplanted, they all died. Whereas out of the 42 who got transplanted, 81% are alive at 1 year. As you would expect, the precipitant, as already mentioned, for most patients, bleeding and sepsis, and all of them were basically grade 3 ACLF. I've just seen Vin arrive in the auditorium, so I'm briefly talking about ECMO, because that's also gone into the EASL clinical practice guidelines, and this patient has arrived with us last week with fulminant Wilson's disease and had a transplant at another center and got referred and retrieved. She's still on ECMO at the moment. And I just briefly mentioned this in relation to liver failure in BOLD. So out of 31, now 32 patients who had a transplant, some of them were actually fairly far out, but the majority during the very early perioperative phase. Out of those 13 had acute liver failure. We've actually treated 22 patients with acute liver failure, but not all of them were transplanted. And on the bottom, you see the outcome to hospital and long-term survival is 42% in this patient group. So in conclusion, I would make a call pro a liver ICU. Liver failure is a fairly rare disease outside acute or chronic liver failure problems. It is very complex. It requires advanced technology and equipment, can be quite resource intense. I think it is very important to have the referral center role and expert, well collaborating MDT, and I leave you with JetGPT definition of what should happen or thoughts in future in relation to liver intensive care. Thank you very much.
Thank you, George, and we're open for questions and comments. Dr. Walid. So we have a question. Dr. Abrar.
Good morning. I actually have two questions, one for Dr. Arabi and one for Dr. Emma. The first one for Dr. Emma is that you have mentioned about the use of indirect calorimetry. How frequent you use it, especially that you have mentioned ultimately you want to achieve 80% of your requirement. So would you use the calorimetry to guide you for that, or you will ultimately actually go for the 80 to 100% measurement? And the question for Dr. Arabi, you have mentioned that...
We'll start with Dr. Emma and then
yeah,
we
okay.
move.
Okay, thank you. Thanks for your question. We do use it in our practice, so I guess we tend not to measure before about day 5, just purely because of the evidence currently showing us that just trophic standard feeding is fine. After about day 5 to 7, we'll start looking at all of the patients in our unit and prioritise them for measurement based on how long we think they're going to stay, how unwell they are, and then we'll start doing a series of measurements. We do try and target that 80 to 100% after about day 7 to 10, so that is our usual practice. Again, we don't know if that's exactly the right thing to do, but our viewpoint is that nutrition over the long term is probably going to be how we're going to assist our patients, and so we do have that as our practice. But we do carefully monitor if the patient gets sick again, we will pull right back and go back to a more low dose, perhaps not trophic, but a low dose feeding strategy again. So in our practice, it is very useful from that point of view.
So you do it on daily basis?
Not daily, weekly. Sometimes twice weekly if the patients have deteriorated or changed, but generally weekly. And that's also a capacity thing. We just don't have staffing to be able to do it more frequently than that. The dietitians do the measurements, so we have to fit that into our workload.
Thank you. The question for Dr. Arabi is, you mentioned that you would like to start the feed a bit late rather than early. So how actually early is harmful? Is it like 12 hours, 24 hours, 2 days? And how late would be harmful as well? Especially that when the ICU setting, we do deal with a lot of different patients, not only those they have abdominal pathologies, lung pathologies, intracranial pathologies, and all of this patients.
So great question. Just to clarify, I didn't say start feeding earlier. The point is, don't start full feeding early. Don't push the feeding to full target early on. But the evidence says at present that you should probably start some feeding as early as possible, probably in the first 24 hours, up to 48 hours. And special patients, you may have to start earlier. But then go slow, especially in patients who are in hemodynamic shock on high dose pressors, because these patients probably will not tolerate higher amount of feeds. The study from Nutria 1 and 2 showed that they have an increase in bowel ischemia, okay, and intestinal pseudo-obstruction when you give too much feeds. So start early, but at low rate, and increase it gradually. Perhaps by day 5, you should reach the full target. However, the switch that Emma mentioned between catabolic to anabolic, we assume it's probably around day 4 or 5, but probably differ from one patient to the other. I mean, you have patients with shock who remain on pressors for a long time, and some patients come fast. Some patients improve quickly, some patients take longer time, right? So we probably have to individualize it, but at this point, we assume that there's early phase, a few days, and there is a later phase or phases of recovery from illness. All the cumulative evidence shows that pushing feeding too much in the first few days probably is not a good idea. It doesn't help, maybe it hurts.
Thank you.
Another question? We have at the front here. While we're waiting for that question, Dr. Arabi, talking about the same subject, when we're talking about protein high or low, what's the evidence? I mean, in the life of sports, protein is always coupled with performance and pushing the muscles to failure to measure the outcome with the muscle mass. So you mentioned that some of the studies showing that pushing protein early at the, let's say, acute phase did not result with good protein or good muscle mass. Whereas there is, inshallah, there is a study ongoing now, which is the replenish for the late protein. And that, could there be, now we're talking apples and oranges. Now with the late phase, when you have a rehab, probably more muscle performance and failure and weaning and would push the protein. Is that the concept?
Of course, I think the interaction between feeding and exercise is so important. So you mentioned sports. I mean, you build the muscles when you give protein, but exercise at the same time, right? But your patients who are in shock and 3 inotropes and ARDS, they don't exercise. You give them protein, but there's no exercise. There are some studies that looked at the interaction between the two, and we don't have a lot of details. It's going to be a hard study to do large trial of active mobilization and nutrition, but that's probably the ultimate way to do it. But I think the combining exercise with protein, probably this is what built muscle mass.
I think we have a question at the front. Thank you.
Assalamu alaikum and good afternoon. This is a question for Dr. Ozinger. So I just want to ask, I'm an intensivist working in a transplant ICU, and we've been resistant actually to the idea of liver ICU previously, but we're undertaking that change. But from your experience, what are the steps that is needed to, and the process that we need to undergo to separate our ICU into liver ICU from the other ICU, from your own experience?
I guess ICU setups are quite diverse across different countries, so I presume you do have surgical versus medical ICUs, so a bit like in the US, and been a bit involved with the liver ITU setup at the Cleveland main campus in Ohio, and maybe similar difficulties in as much it is driven by the medical ICU side, meaning that obviously they only see and treat the patients before they go for transplant, and everything thereafter they are not involved in. I'm not entirely sure if I've got easy solutions. I think, you know, it is something which obviously has organically evolved. And in the UK, ICUs, a bit like in Australia and New Zealand, are usually not divided into medical and surgical. So it is more the fact that, I guess, you know, you're providing the specialist expertise, maybe at the start, for people also to work across 2 different areas. If you have got that problem of medical versus surgical, for then at the next step potentially saying, look, you know, it would make much more sense if we cohorted these patients all together, because, you know, they would benefit from the expertise of one team going with them throughout their patient journey. But I think it's really a probably logistical hurdle and problem, with fractions of people having obviously vested interest. There may be organizational and financial reasons playing with it as well. So I see the same struggle in the States. I haven't really got an answer to your question.
Thank you.
I have one question for you, Professor Ozinger. I'm one of the doctors here in the media ICU in Kuwait, and we're a mixed ICU in terms of medical and surgical, and we see a lot of liver failure patients because we have a hepatology unit attached to us as well. A major issue for us is trying to get these patients stabilized to transfer to a transplant center, which is not always available in Kuwait due to logistics. By the time the patient arrives at that unit, a major issue, by that point, the patient has some element of sepsis, be it fulminant or occult, at which point the vicious cycles develops where the surgeons are not eager to transplant and the view that the patient will need immunosuppression postoperatively. They want to clear the sepsis. That never happens. The patient goes the vicious cycle, deteriorates, eventually passes away. Is that a changing viewpoint in the culture of a liver ICU? Because I've heard certain centers where their treatment is, we'll transplant the patient, as that is going to theoretically remove the precipitant of the recurrent sepsis, or is that rationale still considered valid and is actually a deterrent to admit the patient to liver ICU?
Yes and no. I think, we would be very pragmatic and matter of fact. If patients have got active infection, they will not usually be a candidate for a transplant. It's sort of one of the fairly absolute criteria, exclusion criteria. Having said that, if on treatment things improve, obviously you could make a cogent argument that they're on a positive trajectory and you should revise that opinion. When I'm saying yes and no, it's obviously very easy if the patient is within a center where transplantation is offered and available, because whenever our patients under your roof and discussed constantly and everybody's there to actually see them, it is much easier to make that argument and point. And I sympathize with you in that sense. If you have got the inability to perform transplantation in your country and need to transfer patients somewhere else, there may be lots of arguments being brought up as to why the patient's not a candidate for a transplant. So I wouldn't say, it's always an absolute contraindication. We heard a lot about individualized patient care, and I think this is also a probably quite important and prime example of where things may need to be looked at in a longitudinal fashion rather than making a point assessment and say yes or no, with all the logistic problems you have in case you can't offer the service in-house.
Thank you. One question.
Sir,
Yeah.
good morning, sir. Sir, I want to know about the MARS, the molecular adsorption recirculating system. It is still, I know it is recent studies has against it, but still any role in this world for the bridge to transplant regarding the MARS?
Do you want a short or a long answer? No. Look, I'm always getting suspicious if devices have been on the market and used for MARS now about 30 years, and there is not really a single adequately powered randomized controlled trial which has shown a significant outcome benefit, or indeed a benefit in terms of bridge to transplant. So we've been involved in very early MARS trials in the early 2000s. We've seen quite a lot of side effects. There's quite a few patients where we would say it's not the right treatment to be used. It obviously has got potential advantages like any extracorporeal device therapy does have in terms of having an effect on encephalopathy grade. But the same is true for xenobiotic liver perfusion, charcoal hemoperfusion, which was first reported at King's 50 years ago, but nobody would use it nowadays. So we don't use MARS. We haven't used it for 20 odd years. We've also been obviously involved with other forms of therapy like the Prometheus plasma separation and albumin dialysis combined, again, where we have not really seen any substantial outcome benefit. So the only thing we do is plasmapheresis, whereby I would also say, and I've been involved in the trial at its early stages, there's all sorts of problems with the data, but it's probably the only therapy which has shown some improvement.
Thank you.
One last question for Dr. Walid regarding the residual volume. Whether you follow a strategy or a certain limit, would you tend to liberate yourself from that strategy according to the patient? Sometimes if he enters a rehab phase, training, extubation, that you start tending to be over precocious with the residual. This is primarily to you and open to anyone.
I think the answer depends on practice. If you ask 10 different intensivists, you'll have different answers. Again, gastric residual volumes, in my opinion, if you think about it, it's a diagnostic test. So it depends which threshold you're looking at. I know that many ICUs implement it routinely. The issue is you will end up with a lot of interruption of feeding unnecessarily. Unfortunately, there isn't a gold standard. But with any diagnostic test, if you have a high residual volume, that's a very large volume, even prior to extubation, we usually ask the nurses to hold the feeds and aspirate gastric content. I honestly couple these thresholds with physical examination, patient assessment. Similar to any diagnostic test, it depends on your pre-test probability. As your pre-test probability goes up, your post-test probability will also goes up. But to rely completely just on residual volumes, I think, and again, that's my opinion, you will end up with both extremes, a lot of unnecessary interruptions of feedings, and maybe vice versa, you may miss some patients who actually have something wrong clinically.
Any other questions? Abrar, your last question, and after that we close.
Sorry, I hope I don't take a long time. My question is for Dr. Walid. We do face a bit of problem with our colleagues, the surgeon, when they come to the surgical ICU assessing their patients. And they do mention that we will not start any feed, especially if they do an abdominal procedure and they examine the patient, there is no bowel sound, I will not start anything. Was that a real justified reason not to start feed? And if it is yes, is it a justified reason to start prophylactic prokinetic agents?
Well, again, this will all be an expert opinion. It depends on the bedside assessment. I think if you think about any pharmacologic intervention, you have to have a good rationale for using it. All these interventions are associated with cardiac side effects. They're associated with tolerance. Some of them may, excessive use of antibiotics could lead to antimicrobial resistance. So advocating for using them just, right off the bat might not be the right way to go. So my approach is generally to assess the patient and individualize your treatment. Sorry, I don't have a blanket answer for you to help answer that question. But again, it has to be individualized, in my opinion.
All right, with that, we close the very nourishing session. We learned a lot, and thank you very much for the good dialogue with the questions. Thank you. I think it's time for the group photo. Thank you.